afternoon, everyone. I am Xinyi Qian, and I would like to present to you my 3-month progress towards my PhD on implant placement, loading, and soft tissue management in the aesthetic zone. I'm currently a second-year resident at the Department of Prosthodontics. My vision is to provide the highest quality implant-prosthodontic restorations with the most time and cost-effective workflow while minimizing patient discomfort based on scientific and clinical evidence. And my mission towards achieving this is to implement the best implant-prosthodontic treatment for the anterior region into everyday practice. Currently, I have 2 ongoing projects in this topic. In the first one, we would like to investigate hard and soft tissue outcomes of different placement and loading protocols on single maxillary implants in the aesthetic zone. It will be a systematic review and a network meta-analysis. Based on the newest international guideline on implant placement, implant prosthodontic rehabilitation, we have altogether 12 types of implant placement and loading timings indicated with red numbers. You can see the timing of the implant placement into the bone, and indicated with dark blue letters are the timing of the prosthetic rehabilitation after the placement of the implant. The larger the number or the letter means the later the procedure happens. Conventionally, implant treatment used to follow the type 4C protocol, which is late placement and late loading. However, patients want the restoration of missing anterior teeth as soon as possible. And also the buccal bone is thinner and resorbs faster in the anterior region. Therefore, immediate or early treatments become more and more favored. Based on the previously mentioned international guideline on general placement and loading, they state that the types 1C, 2,3C, 4B, and 4C protocols are valid. However, the same authors have published a newer systematic review in 2021 where they specified the types 1C and 4A protocols to be valid in the maxillary anterior region, which we would like to investigate. However, they did not have enough proof on the validity of the types 1A, 2,3C, and 4C protocols. We also know that the 10-year survival for implants is 93 to 98% and 89 to 94% for implant prosthodontics. But more importantly, they depend on several factors, and therefore we would like to investigate how the placement and loading times affect the hard and soft tissue parameters around single maxillary implants in the aesthetic zone. We would like to investigate patients with single tooth replacement with implantation in the maxillary anterior region. The primary outcomes we will investigate will be implant survival and marginal bone losses, while secondary outcomes will be soft tissue parameters and aesthetic results. We have built 4 PICO frameworks based on the guidelines, and we would like to compare the type 1A protocol to the type 1C protocol. Then we will compare the type 2,3C, 2,3A, and 2,3B protocols also to the valid type 1C protocol. And then we will compare the type 4B and 4C protocols to the other valid protocol, which is the type 4A protocol. Our clinical implication will be finding the most optimal and predictable treatment option in the maxillary aesthetic zone. We've conducted our systematic search on the 12th of October in 4 databases with the following search key. And after selection, I have 27 eligible full texts. After searching through their reference list, I have found 2 more articles. All of them you can see here in this network diagram. All of them are randomized control trials, and I indicated with red those articles that have not yet been used by other meta-analytic investigations. Currently, I have finished about 50% of my data extraction, and I plan to finish all of it before Christmas. My second project, we will investigate the hard and soft tissue outcomes of using either CAD/CAM versus conventional healing abutments for soft tissue healing. It will also be a systematic review and the network and the meta-analysis. As I've mentioned, patients want fast and painless restoration with high performance. The problem with the conventionally used stock healing abutments, which you can see there on purple, that it is too narrow and it is not anatomical, which causes a discrepancy with the later prosthetic rehabilitation, and it causes pain for the patient during the process. However, an advantage for the doctor is that it's very easy to use. On the other hand, the newly arising CAD/CAM individualized healing abutments or provisional crowns allow a one-step formation of the soft tissue, which will require much less adjustments later on, and the procedure would be less painful for the patients. And this disadvantage is that it is only achievable with a pre-surgical prosthetically driven backward planning. Our aim is to compare the hard and soft tissue parameters of either using CAD/CAM individual healing abutment or immediate provisionalization versus the use of conventional healing abutment in patients with single tooth replacement with implantation. And the outcomes we would like to investigate will be marginal bone losses, soft tissue parameters, aesthetics, and patient-reported outcomes. Our hypothesis is that healing with individual CAD/CAM abutments will give better clinical results than with using stock healing abutments. Our clinical implication is still finding the most optimal and predictable treatment option in the aesthetic zone. I've conducted my systematic search on the 1st of December in the 4 databases. And after duplicate removal, I have 3,796 articles. The next step will be the title and abstract selection. Again, you can see an overview of my current ongoing projects. And I would like to thank your attention with a quote from the Greek poet Hesiod. But before the road of excellence, the immortal gods have placed sweat. Thank you.
So first of all, congratulations. So in your first topic, I realized on the diagram that not all of the protocols are connected to each other. So my question is that will you be able to compare them in a network meta in this way?
Unfortunately, yes, you can see that the type 1B and the 2-3B protocols do not have randomized control trials that will compare them to the other protocols. And in the network meta-analysis, we can only include randomized control trials. So, however, we do have cohort studies that compare these protocols. So we will compare them only in the systematic review part. And unfortunately, it will be a limitation of our study. Thank you for the question.
Thank you.
Congratulations for your presentation. I noticed that you mentioned that implantation depends on many factors. So my question is, are you planning to analyze confounding factors on implantation other than the loading protocol? For example, smoking or the systemic diseases?
Yes, thank you for the question. During the data extraction, we actually create groups for patients who are smokers or non-smokers, patients who had any kind of tissue graft or didn't, and also whether the healing procedure was submerged or transgingival. So we do create these subgroups later on.
Congratulations for your presentation. Just out of curiosity, why didn't you include implant survival as an outcome in your second project?
Actually, first of all, implant survival, even in our first project, it is pretty high and it does not give us that much information. But in the second project, as I have read from the articles, basically all of the implant survivals are 100%. And the other reason is that in the second project, we would mainly like to investigate the soft tissue outcomes. And the using stock healing abutment or individual healing abutment does not really have that much impact on survival.
Regarding the second project, that I wondered that in the last few years there are some prefabricated anatomical healing abutment are available from some companies. So it's anatomical, but it's not individually shaped. and it gives maybe the same result, and it's much cheaper and easier to use them. Do you want to incorporate them, include them in the studies?
Yes, we did consider including them, but the problem is we thought that we already included the CAD/CAM individualized healing abutments and also the CAD/CAM individualized crowns. And we think if we also include the stock anatomical abutments, then the heterogeneity would be too high for our study, therefore we did not include them.
From the other side, it's more standardized because you can select based on the tooth number, and that's always the same between the studies. So it's not heterogeneous on the other side, because if every dentist designed for every patient different shape of the individual abutment. So.
Yes, we actually did not conclude our selection yet, but we will see what types of articles we do have, and we will consider it after selection. Thank you.